Hello guys, welcome back to Clinically Clear. Today we'll be covering another very important topic, that is polyp, nasal polypi, polyps, whatever you'd like to call it. So there are of two types, antrochoanal polyp and bilateral ethmoidal polypi. I'll be making two separate videos, but I have this table here to compare and contrast both the types. First, let's define what is a polyp. A polyp is a mass of non-neoplastic edematous mucosa originating from either the nasal cavity mucosa or the sinus mucosa. So what is it? A mass of non-neoplastic edematous mucosa originating from either the nasal cavity or the paranasal sinuses. Now these points here on the right hand side, I'll come to it later after finishing the entire thing. Antrochoanal polyp is also known as Killian's polyp. Important. Bilateral ethmoidal polypi is known as sinonasal polyposis. Here it is known as Killian's polyp. Then, etiology. Generally, it is due to infectious. Antrochoanal polyp is due to infectious causes. Chronic bacterial maxillary sinusitis. And remember, antrochoanal polyp. Antro suggestion of antrum of Highmore, maxillary sinus. So it always originates from the sinus of mucosa of maxillary sinus. So chronic bacterial sinusitis where? In the maxillary sinus. So chronic bacterial maxillary sinusitis, or it can also be allergic fungal sinusitis. In allergic fungal sinusitis, there are two characteristic things: very thick mucinous discharge, and the infection tends to take up metal from the atmosphere. This leads to a sign known as double density sign. As you can see here, you have two different densities, or it appears like a railway track. So double density sign or railway track appearance seen in fungal sinusitis. So basically just remember the two causes: chronic bacterial maxillary sinusitis or allergic fungal sinusitis. It is infectious in nature. It is due to local infections. Then parts of the antrochoanal polyp. Remember that the antrochoanal polyp always, it starts from the maxillary sinus mucosa. So let's assume this is the maxillary sinus mucosa somewhere here. This part that is attached to the maxillary sinus mucosa is known as the antral part. It forms the stalk. This stalk should come out of the maxillary sinus to enter the nasal cavity. How does it come out? Now, maxillary sinus has two ostia. It has the sinus ostia and the accessory sinus ostia. Most cases, polyp always comes out through the accessory sinus ostia. So it comes out through the accessory sinus ostia, it enters the nasal cavity. Now, it can grow two ways. Two parts grow two ways. The anterior growing part, it comes into the nasal cavity. The part that grows anteriorly is flattened from side to side. It is very small. It is the nasal part. Why? Because anteriorly our nasal cavity is very narrow. It gets narrower and narrower. Whereas the posterior part is the globular part. It is large, it is globular, it keeps growing quickly. So this is the choanal part. So the antral part forms the stalk, the posterior large globular part is the choanal part, and the anterior part is the nasal part. So this is about the parts of the antrochoanal polyp. Now, symptoms. As I said, antrochoanal polyp, you have to remember that it is always it starts only from one side. It initially causes unilateral nasal obstruction, and you always have only one antrochoanal polyp. So, and any nasal obstruction is always felt more during expiration. You might have experienced this when you have a nose block. Yes, it is difficult. Let's say you have a nose block in 1 year. You try to forcefully inspire, some air will enter. But then after that, when you try to expire into the nasal side with the block, then you'll feel intense discomfort and irritation. That is because the nasal obstruction is always felt more during expiration. So before we get to that, let's look at a 3-mark answer. That is, what are the causes of unilateral nasal obstruction? Other causes. At the level of vestibule, what could be the cause? Any furuncles or boils, any unilateral vestibulitis, any squamous cell carcinoma at the vestibule, unilateral nasal obstruction at the level of nasal cavity, any foreign body aspiration, any C-shaped deviated nasal septum, antrochoanal polyp, or any rhinolith, all these cause unilateral nasal obstruction. Then at the level of nasopharynx, unilateral choanal atresia, meaning only on one side there's a membrane covering the choana. Atresia is membranous closure. Stenosis is narrowing. So that is at the level of nasopharynx. So whenever there is nasal obstruction, what some symptoms will be common to any case of nasal obstruction, like rhinolalia clausa, hyponasal voice, and hyposmia, nasal discharge, hyposmia, nasal discharge, recurrent sinusitis, all this because why? Because of the nasal obstruction, the mucus discharge, the secretion is not being cleared, so everything begins to accumulate there. So there is discharge, there is reduced airflow, so hyposmia, there is reduced airflow, so hyponasal voice, and there is recurrent sinusitis. Why? Because of accumulation of secretions. It is not getting cleared back into the nasopharynx. Then one very important thing with antrochoanal polyp is, okay, it starts as unilateral nasal obstruction, but if the antrochoanal polyp grows large enough that it goes all the way, the choanal part grows all the way through the choana into the nasopharynx and keeps growing, and it goes and obstructs the choana on the other side. See, choana, it came from the maxillary sinus, it entered the nasal cavity. The choanal part kept growing posteriorly, it entered the nasopharynx, and then it blocks the choana of the other side by growing laterally. So then it will cause bilateral nasal obstruction. So unilateral nasal obstruction becomes bilateral nasal obstruction. This is the symptoms. Signs is what you look for. When you do anterior rhinoscopy, most cases actually it appears normal. Why? Antrochoanal polyp mostly grows posteriorly. I told you, it is the choanal part that is large, that is globular, that is growing posteriorly. Whereas if the antrochoanal polyp is a very, very large polyp, then you might be able to see it. And when it is so large that it sometimes can even protrude through the nostril. That can also happen. Okay. But this is what, in majority cases, it appears normal. But posterior rhinoscopy, you will be able to see. Why? Because when you do posterior rhinoscopy, you're looking at the choana and the nasopharynx. So there you can see that large globular choanal part filling the nasopharynx, blocking the choana, and even hanging down into the oropharynx. Then, when I go for diagnostic nasal endoscopy, what can I see? I can see that there is a soft, trilobed, grey, glistening polypoidal mass covered in mucus. Understood? And what will I do? I will do probe test. I will pass a probe and I will try to move it around. In a probe test, there are 5 things you can find in a polyp that helps us differentiate it from other things. That is, a polyp, you can completely pass it around. See, let's say I have, this is my surrounding wall of the nose. The polyp is coming out. A polyp, I can completely pass the probe around the polyp. Whereas if it is a turbinate where it is attached to my the wall, I cannot pass the, I don't know how to describe it exactly, but you cannot pass a probe all around the turbinate because the turbinate on one side is attached to the lateral wall, right? But you can completely pass it around the polyp. And polyp is insensitive, it is just edematous mucosa. Whereas if I touch the turbinate using a probe, patient will immediately start sneezing, start feeling discomfort. Then polyps are soft, turbinate is bone, it is hard. Polyps are mobile and there is no bleeding when you touch a polyp. Whereas if it is a turbinate and you touch it very with a lot of force, or if it is any malignancy, highly vascular, if it is angiofibroma, then there is chance of bleeding. So that helps us differentiate it from turbinate hypertrophy. Then X-ray. When you do an X-ray lateral view, you can see that the nasopharynx, the choana, it is even hanging down all the way to the oropharynx, a polyp, an opacity. Now, how do I differentiate this opacity from adenoid? See, adenoid will also fill up the nasopharynx. It will also appear the same way. But in antrochoanal polyp, you can see this air gap between the posterior wall of the nasopharynx. This is the posterior wall of the nasopharynx, right? And the polyp. You can see an air gap. But in adenoid, this air gap, this crescent sign, this air gap is known as crescent sign, it won't be seen. Why? Adenoid itself is attached to the posterior wall of the nasopharynx. So why will there be any air gap? Got it? So crescent sign, not seen in adenoid, seen in antrochoanal polyp. And when I do a coronal CT, I can see that from the maxillary sinus, there is an opacity, it is coming out. I can't see it growing posteriorly, of course, in a coronal CT, but you can see the opacity from the maxillary sinus. Then coming to the differential diagnosis. Differential diagnosis, basically what is important is elderly individuals. If it is an elderly individual, then you have to always be careful of malignancies. Malignancies, but they are more firm, they bleed on touch. But just probe test, you cannot differentiate. You have to always send a send the polyp to biopsy after excision. Angiofibroma, even this will bleed on touch. Then you have a blob of mucus, where a blob of mucus is one of the differential diagnoses where it can be blown easily. And then you have turbinate hypertrophy. Turbinate hypertrophy also appears very similar to polyp, but when you do a probe test in turbinate hypertrophy, you have the complete opposite findings to that of polyp. You will find that patient sneezes when you touch the mucosa. You'll find that it starts bleeding. You find that it is hard, it is immobile. You cannot pass the probe all around the turbinate. So turbinate hypertrophy is one of the differential diagnosis. And you also have concha bullosa. What is concha bullosa? It is pneumatization of the turbinate. So when there is pneumatization of the turbinate also, there can be, it can appear like a polyp. So it is one of the differential diagnosis. Here also you are differentiated through probe test. And in infants, the differential diagnosis is more of meningocele, meningoencephalocele, etc. Meningocele, meningoencephalocele, etc. So what is the differential diagnosis for polyp? In elderly patients, it is malignancy. It can be malignancy. It can just be a blob of mucus. It can be pneumatization of the turbinate, that is concha bullosa, or it can be hypertrophied turbinate. It can be angiofibromas. It can even be, in case of infants, meningocele, meningoencephalocele, or any congenital tumors. So that is about differential diagnosis. Then coming to the management of antrochoanal polyp. Now always before we go to surgical management, we prefer to do conservative management. So we give steroid, intranasal steroid nasal spray, so that there is so that to decrease the size of the polyp, we give intranasal steroid nasal spray. But we will not give this steroid nasal spray for antrochoanal polyp. Actually, this is wrong. Just ignore this. But yeah, we'll give intranasal steroid spray to decrease the size of the polyp or to suppress early polypoidal changes, and pre-op also we'll give it for reducing the size of the polyp. But see, generally medical management does not work for polyp. We have to go for surgical management. So surgical management is the gold standard. Now in the olden days, we used to do simple polypectomy, where using snare dissection. What is a snare? Snare is basically, to a probe you have a wire attached. So what we do is we pass the polyp through the wire. Let's say this is the wire, and then when we pull this probe, the wire cuts the stalk of the polyp. I hope you guys understood it. Not a very accurate demonstration, but just the principle of it. So simple polypectomy using snare dissection, we try to cut the polyp. But the problem with simple polypectomy was there was a high rate of recurrence. So the gold standard surgical technique for polyp is always functional endoscopic sinus surgery, FES. Functional endoscopic sinus surgery, or FES, is minimally invasive and it has a very low rate of recurrence. So that is the gold standard treatment. But even after doing FES, if there is a high rate of recurrence, then we'll go for Caldwell-Luke approach. Now what is Caldwell-Luke approach? It is a very invasive procedure. Only when it's required. This is not generally preferred. See, we make an opening, we make a window in the anterior wall of the maxillary sinus. We know that above the second premolar and the first molar, if we make a hole, window, it enters into the maxillary sinus. So through that we enter the maxillary sinus and we cut the polyp. And remember something, always, whenever you cut a polyp, whenever you dissect a polyp, excise a polyp, more correct term is excision of polyp, you have to always remove the surrounding mucosa along with the stalk. To prevent recurrence, to avoid recurrence, you have to always do that. And remember, give post-op steroids also to reduce recurrence. Now, this is about treatment. Surgical treatment, gold standard is FES, understood. Olden days, simple polypectomy, high rate of recurrence. If too much recurrence even after FES, then go for Caldwell-Luke approach. And always suspect malignancy in elderly, and any polyp, once you excise it, send it for biopsy. You have to rule out malignancy. That is standard procedure. Coming to the differences compared to bilateral ethmoidal polypi. Antrochoanal polyp, this is to compare it with bilateral ethmoidal polypi. Antrochoanal polyp is more common in children. Bilateral ethmoidal polypi, adults. Antrochoanal polyp grows more posteriorly. Bilateral ethmoidal polypi grows more anteriorly. Antrochoanal polyp origin is the maxillary sinus mucosa. There it is ethmoid sinus or osteometal complex mucosa. Here the cause is local infections like chronic sinusitis of the maxillary sinus. There it is multifactorial causes, most commonly allergy. Here unilateral polyp and it is just one single polyp. There it is multiple bilateral polyps. Here less chance of recurrence. Bilateral ethmoidal polypi, higher rate of recurrence. This is a trilobed polyp, whereas the bilateral ethmoidal polypi are multiple grape-like masses. Here, initially you have unilateral nasal obstruction, which later becomes bilateral nasal obstruction. And then you have, whereas in bilateral ethmoidal polypi, you always just have bilateral nasal obstruction. So that is to help us differentiate. So that is it for antrochoanal polyp. I hope you guys enjoyed the video. Thank you for watching.